All right, welcome everyone. We are here in week number 7 of our palliative care focused on humanitarian settings for East Africa, an introduction to the course. My name is Erin, and I'm a palliative care nurse currently living in Kenya, and really happy to be here. We have several of our faculty members with us today. I'll introduce the ones that are not speaking, and then I'll introduce the ones who are speaking. I've renamed most of our faculty, so you should be able to see a hashtag in front of their name. If you're looking for someone who's one of the faculty members, you can reach out to them, private message if you want. So we have Esther Beatty. She's here with us today. She's going to join for the first hour or so, and then she might need to leave. She's a palliative care nurse from Canada working in Senegal, which is wonderful. And we have Ali Hamid, who is our clinical officer in Dadaab refugee camp in Kenya. He's been working in the humanitarian setting in the camp for many years now. So he's one of our local experts and faculty members, and he's, I think, has had 100% attendance on this course already, which is amazing. Ali, you've been right there with all the participants, which is great. And I don't know if there's any other faculty with us today. I don't see anyone else. So I will now introduce our topic and our speakers for today. We're really honored to have Kelemen be our main speaker. She is a social worker and the director of Psychosocial Palliative Care in Washington in the United States. And she'll be talking about trauma-informed care related to palliative care. So she'll be walking us through that. It might be a new topic or a new word for you. In English, we say trauma-informed care. I would love to hear what that would be translated into some of the local languages or, the languages that you work in. But maybe we can have that as a discussion question after Anne. Anne has been a faculty member with us for several years now. She started working with the Project ECHO team in Bangladesh, and now she's continued to support improving access to palliative care knowledge and skills in East Africa. And Dr. Jessi Humphreys is going to be with us today. She'll be going over the case, and she is also working in the US on the West Coast, I think San Francisco, right? And she is, she'll be sharing a little bit more at the second part of the session. So we're really glad you're here with us. Dr. Jessi's been supporting our team since last year, which is great. She's quite interested in wanting to promote palliative care in really difficult settings in places where you work. So we're glad that you're with us today. Please introduce yourself in the chat. I know we haven't had time to allow everyone to introduce themselves, but just put where you're working and what you do and your name. It would be great to meet all of you. Just a reminder to keep your video on if you can, if you're able to and your network allows it, and then just stay muted until we come to the discussion time. All right, Anne, it's over to you, and we'll go from there.
Thank you. It's very exciting to be here today and to see all of you. I'm going to go ahead and share my screen and pull up my slides. Okay. Does that look okay? Can you hear me?
Yeah, looks great. Thank you.
Okay. So the topic today is supporting patients with psychosocial distress using a trauma-informed care approach. So we're hoping to describe trauma-informed palliative care and describe the stepwise approach to trauma, and then name some common ways that we can care for people using this with distress and trauma at end of life. So defining trauma, how do we define trauma? I like the definition that's used by the Substance Abuse and Mental Health Services Administration, SAMHSA. Individual trauma results from an event or a series of events or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So as an example, an event could be a diagnosis of cancer, or a series of events could be a diagnosis of cancer that then, because of the symptoms that you have, results in loss of a job. And that results in, some financial distress. And then physically or emotionally harmful, you could be having physical pain due to loss of a limb, or emotional pain due to loss of a child. These are all kind of examples of trauma. Or life-threatening. If you think of genocide or war or really serious illness that's threatening your life, are all just a few examples of how trauma can show up. And so when we talk about trauma-informed care, what do we mean? And trauma-informed care is really an approach that assumes that an individual is more likely than not to have a history of trauma. And trauma-informed care recognizes the presence of trauma symptoms and acknowledges the role that trauma may play in an individual's life. It's similar to a central social work theory as a person and environment perspective. And we may have discussed this previously throughout the 7 weeks of really not being able to understand an individual unless you understand their environment. And with that, if they have a history of a trauma, really understanding how that now informs how we move forward in care. And so just like I was saying, understands patients' life experiences in order to deliver effective care. And it has the potential to improve patient engagement. One of the ways that you can start to understand this is, some simple questions of tell me a little bit about yourself as a person, and recognizing that in the first couple of visits with a patient and family, you're not going to be able to really understand all of their trauma. But over time, as you work on building a relationship and building trust, and you learn more, then you can learn how those past experiences may be influencing them throughout the course of their illness. So what are some of the treatment challenges with using a trauma-informed approach in palliative care? So we have limited time. We may only see patients, a few times. And there's also limited time that providers have to spend with patients. Most traditional treatments need access to mental health providers, and you may not have access to mental health providers in your clinic. And even here in my setting, we're very fortunate to have 5 mental health providers within our palliative care team. But even with that, treatments, often traditional treatments for trauma-informed care, like EMDR, which is eye movement desensitization and reprocessing, those typically take 8 to 16 week sessions with a trained therapist. And a lot of EMDR therapists don't take insurance and may charge, a lot of money. So there's a financial disparity there. And then also therapy sessions, are usually 50 minutes and sometimes 90 minutes for severe trauma. And somebody who is really sick and may already have trouble getting to so many of their medical appointments just may not be able to have, even if they had access to therapy, be able to sustain those kind of long treatments for the traditional trauma-informed approaches. So when we talk about palliative care and trauma-informed care, illness can really serve as the primary traumatic event. If you think of a diagnosis of cancer, that can be traumatic, or heart failure. We see a lot of heart failure patients where I work, and I see a lot of people who have recurrent trauma from shocks that they may receive from an internal defibrillator or an ICD. And then with past trauma, war or genocide, memories can be reactivated as patients enter the last phase of life or when they're diagnosed with a serious illness. So an example could be, war veterans who can't handle loud noises when they're in a hospital, or maybe somebody that has a history of forced abortions, and then when dying, they might have unprocessed grief or loss or trauma, or somebody that has a history of sexual assault. So I'm just going to put this case, and I know that Dr. Jessi is going to be talking more about a case, but as we go through one of the approaches that we are going to outline, just think of an example here. So we have a 55-year-old with a new diagnosis of ovarian cancer. and she reports fear when trying to fall asleep at night. She describes flashbacks and nightmares related to genocide and a history of abuse, and recently has missed 3 clinic appointments. So as we go through kind of the approach, think of ways that you may work from a trauma-informed lens to help care for her. So it often can be challenging in figuring out, where to start. And one of the ways is really just first recognizing that this is trauma, being mindful of the distressive memories, the lack of sleep, the intrusive thoughts, and the avoidance of clinic appointments can often be signs of past trauma. Really focusing on listening and building a relationship, sitting down in your clinic or if you're in the hospital setting, and expressing empathy, statements around, I can't imagine how difficult this must be. I can't imagine how scary this must all be for you. So when we talk about serious illness and post-traumatic stress disorder, receiving a diagnosis of a life-limiting illness and experiencing related symptoms like pain or shortness of breath, can elicit a lot of feelings around helplessness or hopelessness that could be the index trauma or a trigger of past trauma that may be coming up. So some ways that we can help to focus and to treat this is one of the ways when we talk about coping, people living with trauma may be prone to avoiding coping strategies. So, for example, remaining physically and mentally occupied. If one of the ways that I always coped with my previous trauma would be that I stayed active and I was running. But now when I was diagnosed with cancer, I'm not able to stay physically active. So I have sort of lost that coping skill that had worked for me for many years. And being able to maybe work with the patient to identify new coping strategies that may help. Medical decision-making can be extremely challenging under normal circumstances, but with somebody that has a history of trauma, the anxiety and emotional challenges that accompany trauma and serious illness can impact a patient's ability to make decisions. And so one of the ways could be good to include other family members or a surrogate decision maker in clinic appointments and in really serious medical decision-making. And then being aware of functional decline, illness-related functional decline can lead to you relying on others for care. And some coping strategies with trauma would be isolation and not wanting to be around others. And this can be a trigger when an illness progresses and somebody then has to be cared for or rely on family members for care. And so being mindful of processing that with patients. And just a quick note, on medications, certain sedative properties like benzodiazepines may precipitate intrusive thoughts or hyperarousal symptoms. So just being mindful of what medications when you're prescribing. And then finally, pain. It can be complex relationship where, pain influences PTSD symptoms and vice versa. So an example would be, physical pain precipitates intrusive memories, which amplify the pain experience. And some patients, may welcome pain relieving measures, or some may have, a history of substance use. So being mindful of if somebody, has been in recovery for a number of years and is concerned about taking pain medications, which may be very helpful for their cancer diagnosis, and being mindful when you're prescribing and to coming up with the best plan. So David Feldman in this article outlined the stepwise psychosocial palliative care. And so the first step in this, and this is 3 kind of easy steps to go through when caring for somebody who has a history of trauma. So palliate immediate discomfort and provide social support. So first is developing a trusted relationship by actively listening, expressing empathy. Like we had said, I can't imagine how difficult this must be for you. And then, if possible, adjusting changes to the physical environment. So if you are in a hospital and it's possible that loud noises are triggering for somebody with a history of trauma, or even having a roommate, if there's a possibility to get the person a private room or a room that has, less noise. And then step 2, provide psychoeducation and enhance coping skills. So education about medication, care plans, and the dying process, and teaching patients skills to cope, like breathing exercises or relaxation training. I'll go over one quick breathing exercise at the end that can often be helpful. And then finally, treat trauma-specific issues. So it's important to note really only moving to this last stage when earlier interventions, have adequately alleviated suffering and physical symptoms. And also if the prognosis is longer, because you're not going to be able to do longer term treatment for trauma if somebody has a really short prognosis, because the traditional trauma-informed trauma treatments like EMDR may take 8 to 16 weeks. And so if you're seeing somebody who is very close to end of life, just really focusing on the first 2 steps is what's recommended. And so I'm going to stop sharing my screen. And before we move to the case, one of the suggestions is to do breathing exercises. And a very quick kind of breathing exercise that you can do in a clinic setting with a patient, and maybe some of you already do this, is really just teaching somebody to take 3 in breaths and then 1 extra out breath. So if they're not comfortable, if they're short of breath and they can't do 3, you can just do 2 and then the longer on the out breath. So you would just breathe in 1, 2, and then you would take 3 on your out breath. 1, 2, 3. Another thing that works well in a clinic setting is like with another relaxation breathing exercise is like visualizing, like smelling flowers. So like taking a breath in and smelling flowers and then like blowing out a candle. And that visualization can help, but it's also a little bit easier for people who maybe if somebody is having a lot of shortness of breath. I don't know, Erin, if you use any other breathing exercises that have worked, but those are the simple ones that I know.
Yeah, isn't there one where you hold your hands on your belly and try to like make your belly go out? Also, is a good way to practice deep breathing and making sure you're sitting with your feet on the ground, sitting straight. Yeah.
And then there's also one that reminds me of like the 5 finger where you can like hold your hand up, and when you're like tracing your finger here, you can just, this is like the in breath and then the out breath. And you can just do that across your fingers. I think they do that in pediatrics a lot.
Nice.
So.
Yeah. Does anybody else have a suggestion? Ali, do you have good ways to encourage your patients to take deep breaths?
Good afternoon, Erin, once again. Outside, we normally attend patients who had post-trauma, stress disorders, mostly, and we have also Department of Mental Health in our setup. In case of such patients, we normally refer to mental health clinic. So they are being given support from their counseling, psychological counseling, and support. We normally give us counseling support and how to handle such patients at the home level, and they also bring back to the patients for their appointments.
Yeah.
We normally have cases there. We have that department.
Nice. Yeah, so I think if you are finding right in the moment of your appointment with a patient, they seem quite anxious and even maybe something you've said or something that has happened that day has caused a trigger to happen, it is good to make sure you know who to talk to. If there are other people on your team, even like Anne was saying, her team has other providers, it is really good to know where we can refer. And then, yeah, making sure you teach the family members how to help. Yep.
I just wanted to add that I think in the situation, often in the context there, it's very important to actually breathe with the person. So get them to focus on you and just say, let's breathe together. Because it might be hard to describe and get someone to understand exactly what you're trying to say. But if you can say, hey, let's focus on me and let's just think, let's breathe together. And
Yeah,
see
it's a
if
great
that
idea.
helps.
Yeah. Yeah, for sure. All right, and I can put it in the chat to see if anyone else has any other ideas, if you want to. Is there 3 steps? We're on one more, right?
Oh, so the last step, I can go back to my slide. So the last step
Okay,
really
so sorry.
is talking, yeah, that's okay. The last step is just treating specific trauma issues. So a lot of times in the settings that we're in, we're really focusing on step 1 and 2. If there is time and somebody has a prognosis that are going to maybe be living, you know, more like weeks or months, probably more like months, you can focus on, if you know their prognosis and energy levels permit, the use of longer term strategies. And that's when really referral to a mental health provider, if you have access to that, because that's when the patient can be referred to do those longer term treatments like EMDR or somatic experiencing and things that work for longer term trauma.
Yeah, all right. So let's open it up for discussion. Anne, I don't know if you had any particular questions, but I'm quite interested, especially because we know in your settings, many people have been displaced. So they're either refugees or they are internally displaced people. What are some common traumas that you are coming across, especially with people who have palliative care needs? If you want to put that in the chat, or if you'd like to unmute or raise your hand, I think sometimes as we talk and openly talk about traumas that people have experienced, we can also gain confidence to talk about it, to be willing to ask about traumas that people have experienced. I think in palliative care, we do really value holistic care for patients. So as we talk more about it together in a safe environment such as this call, maybe we will gain more confidence to find ways to support our patients. So what are some common traumas that you find? And then the next question we can do is how do you find you can help people in your setting? I
I'll just
know
jump
from a
in
lot
through
of, sorry.
Oh, what I was going to say is, as people are thinking, is that sometimes it can be hard to even recognize what the past trauma may be, because somebody just might be presenting with a lot of symptoms or hyperarousal symptoms or not being able to sleep. And we tend to want to medicalize that by perhaps prescribing something for sleep rather than really exploring, you know, what may be on their mind, or if they're having, you know, trouble falling asleep or staying asleep, or if they're having a lot of racing thoughts. So that can even be important questions to help with an assessment.
Yeah, I think, sorry, I didn't get all of that. My son was crying. Yeah, do you find as you work more with people who've experienced trauma that you are able to identify some things like reading between the lines even, or just knowing their story a little bit?
Yeah, I think a big part is once you have that trust built and you may notice, you know, some signs of what, you know, whether it be that they're having trouble sleeping. A lot of people that I see that have medical trauma, like are worried or scared about procedures that may be coming up because previous things have happened in procedures in the past. That is, I think, easier to identify than maybe a childhood trauma, because if I'm seeing, I mostly see adults, so it can be harder to recognize, or at least in the beginning, over time as you get to know someone. It looks like there's something in the chat. We refer people to mental and psychosocial support team for assessment and counseling. That's good.
We
And
had an
even if-
interesting case.
Yeah, go ahead.
We had an interesting case, and I think also through this course, we've shared several cases where people have experienced loved ones who have died due to illnesses, of course, due to conflict in many settings. And I think we can sometimes, I don't work directly with refugees, but of course, as we're supporting more work in the camps in Kenya, people can become a little bit numb to these types of traumas because, 90% of their patients have a loved one who has died due to the conflict or due to being displaced. So, but I think it's really interesting to talk about this and identify that these kinds of losses really do impact our patients. And we cannot take it for granted that each person is going to react the same way the previous person reacted because also their son died, sort of thing. So trying to be as individualized in the care that we give to our patients, despite some of the common traumas that our patients experience. We had one woman not in a refugee camp, but in Kenya, and she was there with her 4th child in the hospital. The child was not doing well and was most likely going to die in a few days. And she had shared, and I don't really think she had much opportunity to share previously, but 2 of her other children had died. One was stillborn and one died traumatically when they were 3. So she had really serious losses and wasn't really able to talk to the team about this current child not surviving. So it was quite interesting and very, very heavy to talk to her, but I think we were able to give her better care once we knew that. Again, we didn't focus on it the whole time because it was very distressing to her to be in those moments, but because of what we knew, we were able to be very sensitive and let the rest of the team know, obviously in a confidential way, what was, what other ways they could support her. There's some good stuff coming in the chat. Of course, like Mohammed Tawane is one of our MSF palliative care nurses working on a team that's been providing care in the camp for about 12 years. So they have a very good referral system. They're a small team, but he was the one who had mentioned they referred to mental health for psychosocial counseling and follow-up. And I know we have several counselors on the call and psychologists on the call, which is great. So if you feel like you would like to unmute, just put your hand up and we'd love to hear from your perspective as well. Esther is just asking, is it okay to talk about trauma in your culture? And then Bush Rai is mentioning that sometimes it's a gender difference. Men in most cultures don't talk about these traumatic experiences, as sometimes it's considered a sign of weakness. And then Millicent says that her patients that present with trauma from physical and emotional abuse, those who have gone through surgical procedures that lead to loss of a body part, that's serious trauma of loss of a loved one, of course. And we usually provide psychotherapy. So that's really helpful. Millicent, where are you working right now? Are you in a community-based setting or a hospital? Maybe you can just put in the chat where you're working, because I know depending on what setting we're in, sometimes we do have more resources available, which is great.
Yes.
Dr. Luwaga, it depends on the trauma the patient presents with, but in most cases we refer them to different counselors or social workers, which is great, which is really helpful, especially just identifying that if someone is struggling beyond what you can support them in, it is really helpful if we can be fairly urgent in these referrals. Oh yeah, and then the MSF team sharing in. In our setting, there's so many psychosocial unmet needs compounded with terminal illness that sometimes dealing with them is draining. And it's really true. And the only option we have is to refer them for further support, mental health. Yeah, I think the type of patients that we see, especially in humanitarian settings, have compounded trauma. I think it's a really good point. And I think part of this course that we're doing here at Project Echo is we're trying to help you all identify, again, that safe community that we can talk to about these things. And is a really good resource. She's not available in our time zone here in Kenya, but she is definitely available if you come across a case that is really challenging, or it seems like you don't really have a good referral source after the palliative care consultation or after you visit them. Please do reach out to her because I know that she really wants to be there to support you guys in your work. Oh, someone has mentioned head injury, so that's interesting. And you guys support people with this type of physical trauma as well.
Yeah, we do. And I was in a training recently, and we're talking about sort of, let's say, after an immediate trauma, like maybe a motorcycle accident or a car accident. And if you're seeing somebody immediately, I had asked who was teaching this sort of trauma-informed talk, what's the best thing you can do? And her advice was making sure that you're using a soft voice, explaining everything you're doing. So if you're a nurse and you're at the bedside and let's say you have to give medication through an IV, even if you think the person isn't awake, she sort of described it as their nervous system will have a memory of this trauma. And the best way to to help can be to just using a very soft voice, identifying them by, maybe, calling them by their name. Erin, I'm going to touch your arm. I have to give you this medication in your arm. This medication is called morphine. It's going to help with your pain. And that was really helpful for me because sometimes it can be very chaotic in a medical setting after those acute traumas, of just being able to, slow yourself down in a way, to use a calm and soft voice. And she described if there then are next steps and the person is improving, where they're becoming more alert, just slowly explaining, like, you are in the hospital, there's a nurse here who's going to help you, there's doctors here that are going to help you, to reassure the person that there's a lot of people caring for them. I thought there was really good practical tips immediately after a trauma.
Yeah, for sure. And I know a lot of our participants are not necessarily in formalized palliative care roles, just because based on the institutions or the organizations that they work for. So most likely people would be doing multiple different things and having multiple roles. So I think that's a really good point, just as we try to provide this type of care. Yeah, Dr. Jessi?
I just wanted to mention something around pain control in those situations. And I wanted to highlight that we actually, I'm thinking of a couple of studies that we did in the United States taking care of individuals who were in war and who were injured in that situation. And they studied giving people a dose of morphine after an injury. And they found that later on in life, they had less, the people who had gotten morphine during that act, whatever it was, if they were exploded by a bomb or something, had some acute injury. Later on in life, they actually had lower rates of trauma diagnoses like PTSD. So I want to just highlight that, because even if you're not working in psychology or sort of the full trauma interventions, some of the really core pieces that you do around treating people's injuries, giving pain medications for even non-palliative care things, sort of the class they think about, like motorcycle injuries, have the capacity to actually decrease the risk of trauma longer term. So something for us to think about in all kind of areas, not just in palliative care.
Right. All right, well, there's one other comment just about talking about trauma. Edna sharing that few talk about trauma, especially men who feel like it's a sign of weakness. So that seems to be a common theme, but men plunge into alcohol and substance abuse or become abusive and neglect their family. With loss, many condone women and forget children and men, console women, I guess. So I think these are really good things that we're kind of bringing to the forefront today. This is not an easy course. These are really quite heavy topics that we're talking about. But we know that you guys are on the front line. We know that there's not a lot of places to reflect and openly talk about some of these things. And of course, today is just a basic introduction of this type of work. If this is something that you're finding you are doing on a regular basis, not only learning ways to integrate palliative care better into your work, but now also this aspect of supporting people through trauma, and you're finding that it's too difficult or it's not easy and you'd like some more support, please do reach out to us. Anne is always around. I know how to get in touch with her. And of course, I'm sure she can put her email in the chat, so we can also email her too.
Yeah. I'll do that. One of the things I was thinking of too is making sure you have, a person that you work with that you can talk about and sort of debrief. I think debriefing is really important because even no matter how long you've been doing this work, it really catches up with you, the amount of grief, but also the traumatic stories that we are often being present for and listening to and holding space for. So being able to find somebody that you can say, hey, I had this really hard day because a lot of my day was spent in clinic talking with this woman who has a history of trauma. And she was very, vividly describing what she had been throughout her life. And being able to have somebody that you can talk to, another healthcare provider, can also help sustain you in this work. I'll put my email in the chat.
Yeah. One of our regular participants was just asking if there are specific classes on trauma or trauma assessment. Maybe we can get Anne to share just if she knows of anything that people can access. I think that could be something we could follow up with for next week.
Yeah, I can put some of those in the chat, or I can email you, Erin, and to send.
Yeah, you can also. Yeah, you can send it to me. I usually email them once a week. So.
Okay, perfect.
I know every situation is a little bit different. I've just written down all the different places you guys are calling in from: Kenya, South Sudan, Ghana, Rwanda, Cambodia, Uganda, Lesotho, US, Senegal, Canada, I guess. And each trauma will be unique, but I think we do have a shared compassion for people that are going through trauma. And of course, we are coming across people that are also dealing with a life-threatening or life-limiting illness. So yeah, I think if you are interested in getting more equipped to do this type of work, especially with those that have gone through serious trauma in the past, I think that'd be really noble to get more informed about that. So I'm going to now pass it over to Dr. Jessi. This is one of the things that we love with Project ECHO, is to now bring it back to a case, to be able to put into practice some of the things that we've learned during the session. Dr. Jessi, please introduce yourself a little bit better. I think I miss where you're working. I know San Francisco, but yeah, please tell us what you're doing on your day-to-day job.
Yes. And I have like a couple jobs, like so many people I know on this call as well. So no worries at all. I'm Jessi. I'm a palliative care doctor in the United States in California. And yes, I do some work at San Francisco with UCSF. And then I also work with our veterans in a VA as the chief of palliative care, and that's in Southern California. So I'm back and forth throughout California. I also run a global palliative care fellowship for United States fellows. And I've spent a fair bit of time in some other places in Uganda, was in Kenya a while ago, have been really honored to learn from teams like you guys when I've been there, and work in some other places, including India. And I do a lot of work with our veterans, do a lot of work with a lot of populations that experience trauma, and have done a lot of work in trauma-informed care similar to some of our other members here. And I'm going to share my slides, but I also wanted to echo something that both Erin and Anne brought up, which is that these cases are really hard for us. And sometimes the sort of getting numb to them over time is really just a sign that we've seen so much of them. There's a lot of talk in trauma around vicarious trauma, which is sort of experiencing trauma by virtue of being close to another trauma. But there's also been some talk in the literature that that's not the right word, right? It's not vicarious, it's real trauma. And we're really experiencing it as providers. And that it's sort of not fair to use the word vicarious because we actually really feel that and we are impacted by these things too. And I want to say that even reading through cases can be traumatizing. So if anything is coming up for you, absolutely reach out to any of us, take breaks, do whatever is important to you. So I will share right now. All right. You guys able to see that?
Yeah.
Wonderful. And I will say on a personal note, I have 2 children. So I have 2 little boys, age 1 and 3 as well. So some of the things we're going to be talking about in this case presentation is really applying what we've already heard and talked about. So kind of brainstorming what things might cause trauma for the patients we talk about, the cases we talk about, what are the emotions that they experience, and then how to provide brief and focused trauma-informed care, sort of those first lines with a limited amount of time, which we often have. We're going to go through 2 cases. The first one is a young 32-year-old woman with CA cervix who has really bad bone pain and is on IV morphine when she's in the hospital. She's married. She has a 4-year-old son, and her husband left her since having this diagnosis. She stays in the refugee camp with her mother, who's elderly, and her younger sister and brother. She has some help with her child from her younger sister, but her brother is here with her now in the hospital because her sister is with her child, her son. And the nurses tell you that she's screaming out and crying in a lot of pain and wants to leave the hospital despite being in really bad pain, and you're giving her IV morphine, which she can only get while she's admitted to the hospital. And you feel like you've given her enough medication and you're not sure exactly how much to give her because she's still screaming out in that pain. She herself and her brother heard about her diagnosis and prognosis. This is the first time they've heard about it and the unavailability of treatment to cure her condition. So that is new, hard news for her. And she reports that being in the hospital brings back some really strong memories of attacks and feeling trapped while she was in Somalia. And some hospital guards remind her of armed forces. And she feels really out of control at night. And the staff all notice her crying and hitting her bed. So I want to pause here and bring up the chat for myself to see and have you guys type in, what do you think causes trauma for this patient? What are some of the things? We've talked about some sorts of things that you guys have already experienced that cause trauma, but what are the things that you think might be causing trauma for this patient? I'm seeing conflict in the country where she fled from, right? So her past experience. Other thoughts from anything that might be bringing trauma. There may be a different word you use for trauma too, which I'd love to hear. Post-traumatic experiences, absolutely. So experiences in her past. Absolutely. So being separated from her child, right? Her husband leaving her, right? Now not having a lot of her support system that she used to have. Not understanding the diagnosis, right? She just heard it. It's possible she doesn't understand it. It's possible she hasn't really, grasped that new reality. Pain, absolutely. Just being a refugee, absolutely, is really traumatic. That separation from sort of previous life and the support system. Severe pain, life-threatening illness, physical pain. I see loss of financial status. Absolutely, the fear. The lack of stability related to that, and some emotional trauma and physical pain. Yeah, absolutely. All those are exactly ones we saw in the hospital environment, right? That medical trauma of being in a hospital environment, all the things that come with that, right? The isolation of that, the guards that you saw. I think you guys really highlighted sort of similar ones that we highlighted as well, but absolutely just being in the healthcare environment, illness itself can cause trauma, right? Sensitive examinations can be really re-traumatizing, especially for anyone who's gone through, we don't know what, right? Her previous experience in Somalia, potentially witnessing violence, rape, and then the physical pain and experience of going through all her medical issues, and then just all the loss of control, right? That's one of the elements we heard in that definition of trauma is the uncertainty of what's going to happen, right? The fear of something, some event that makes you feel like you're going to die, right? You don't have control over the future. And anything that gives you that sense of loss of control can be really re-traumatizing, can bring up those triggers. And so being in a hospital environment is the epitome of loss of control, right? You're separated from people, you don't know what's going to happen, you don't know who's going to come in when, and not having your supports in that situation. Fear of the unknown, absolutely. What are some of the emotions that she's experiencing? See if we can name them, name the emotions. It's a harder thing to do than we think. Withdrawal, fear, anxiety, absolutely fear, despair, anger, absolutely, depression. Yeah, I'd added guilt is a really common one.
Agitation,
right?
also.
Guilt
Agitation.
at being.
Agitation also.
What was that, Ali? Or something? I'd added guilt is a really common one that people have around all sorts of things, right? People have lots of guilt for, they blame themselves for their husband leaving, blame themselves for being separated from their children. So what can we as healthcare providers do to help? Type in the chat. We heard sort of a focused process from Anne, but what are some things that you might be able to do? And everyone, as Erin mentioned, has different resources in different places. What can we
You
do
can
to
find
help?
a way of, put the patient in counseling, make counseling. Hello?
I'm gonna just mute. Go ahead and just type in the chat.
Yeah, John was just saying, suggesting that they go to counseling, maybe alongside
Counseling, yes,
physical
absolutely.
treatment. Mhm.
Yeah. And psychological support. Yeah, absolutely. So I think you guys highlighted as well, supportive counseling to allay anxiety. Absolutely. Psychosocial support, 100%. If we have those sort of services, that is excellent. We often don't. I often don't in many of the settings I work in, including in the United States. We often don't have really high level of support. And I think even what I want to encourage you, and a huge take home from this particular talk, is even if all we do is recognize this is trauma, that is huge. Because without even noticing it, that will impact the way that you care for people, right? Just recognize. If there's one goal to come out of this, just recognize when there is trauma there. And if you can tell yourself, I see there could be trauma here for this patient, that in and of itself is huge. So I think just recognizing that this is trauma for her, sitting and listening to her story, right? Inviting her to share more with the team, with you, about what's going on for her. Because she's sitting there, she's screaming, she's crying out, she wants to leave, but she's in pain. You're struggling with what to do, right? Oftentimes, cases that have a lot of trauma, they actually cause a lot of anxiety for us. We often feel very torn and confused about what to do. And that's often a good trigger for us to think, I wonder if there's some trauma here. And oftentimes we get stuck without knowing how to move forward until we kind of think about really what's going on with them. Just basically expressing empathy, right? Saying things like, it's so hard to be away from your son. It's so hard to be away from your family. This is really scary. And then thinking about what to do for her in terms of the environment. Could she be cared for at home? Are there ways to, there may not be, right? There may be trade-offs, but thinking about what the next steps are for her. And I think really just remembering kind of this 3-step approach that is very simple, right? First, acknowledging that it's trauma, And then once you do, thinking about this 3-step approach of developing a trusting relationship, expressing empathy, and then thinking about changes to physical environment, thinking about how to change their situation to decrease that trauma re-triggering experience. And I think some things that we heard about as well, but to echo back, some things that can help enhance for coping. And I do want to highlight that although many, and potentially most of the patients that we all see have some amount of trauma in their background, some people will move through life and develop a trauma-related diagnosis, right? Something like anxiety or PTSD. But many people will not. So many people will go through traumatic experiences and will not actually end up with PTSD. So not everyone processes and goes through trauma the same. A lot of that has to do with various variables, including sort of support systems, but some of it is just random and just randomly lands on different people differently. But some things we can do to help some of that coping are exactly as we heard, some of the relaxation techniques, the breathing techniques, and then just providing explanations as well for what's going on and then helping plan. We'll go through a second case and then we'll do our group discussion. A second case here is a 6-year-old girl. She has advanced retinoblastoma that spread to her orbital bones and probably into her brain with Mets. She has really bad bone pain. She's been getting by mouth morphine and she's having dexamethasone for her headache. And you have her in the hospital. Her father is there with her. Wanting to take her to a referral hospital. Someone told him there's a doctor there who can help his daughter. Her mother is home with 3 other young children. And important to note, there was a recent motorcycle accident with the father and his 2-year-old son, leading to major injuries for both the father and the son. He's now recovered. He was hospitalized for a long time. That was a hard period of time for them to make ends meet. And the 2-year-old son now has permanent injuries, is not able to walk and isn't talking. During that time was when the 6-year-old daughter's eye swelling started, but the family really wasn't able to take her in because the father was so ill and in the hospital. And you notice that the father is having trouble sleeping. He's very upset each night while at the hospital. And when the staff tries to talk to them, he doesn't speak or really answer them. And one of the Somali-speaking staff is able to speak to him and learn that the father is having some flashbacks from when he was in the hospital after the accident. So type into the chat, what causes trauma for this family? And I want to also highlight that certainly we can talk about the father very much. And I think important to sort of note what is causing trauma for the father, but also to think about this family unit as a whole, what might be causing trauma for this whole family. The things in their past and their experience might be causing trauma for them. The accident, yeah. The going through a recent actual trauma, yeah, the motorcycle accident. And all of the medical pieces that came, yeah, the fear of the prognosis, right? The fear of hearing about what's going on with the child, yeah, the child's cancer. Multiple different occurrences, yeah. Yeah, another child has become disabled, absolutely. And potentially the guilt around that, yeah. That's a traumatic accident that's happened recently. And then sort of feeling the experience of being back in the hospital. Yeah, the social economic constraints around what has happened, right? Being in the hospital for some time and now being in potentially a situation where they're less able to financially support themselves and having now a child with cancer. Yeah. Absolutely. So the healthcare and illness itself can absolutely cause trauma, right? And all of the financial issues that come with that, right? We know that it was probably expensive for him to be in the hospital after an accident for some time. Potentially guilt that this child, the 6-year-old, did not receive care due to, the father's accident and not being able to, even though they really couldn't. The loss of support while in the hospital, right? The child's mother is the father's primary support and she's not there. And then for the father, really fears about his child's future pain, suffering, end of life, what's going to happen. And I think important, even though the daughter is our child, is our patient here, just recognizing that trauma can impact the entire family unit and thinking about the parents as well when we're taking care of kids. Let's talk about the father quickly. What emotions may he be experiencing? father, I'm not sure if you're mentioning this as an emotion, but not being able to earn something for himself. Like he may have shame around that. That may be an emotion he's experiencing, and helplessness. Yeah. We talked about guilt already. There may be a lot of guilt around being in the situation and feeling at fault, anger, fear, despair, worthlessness, anxiety. Absolutely. And what can we as healthcare providers do to help? What are some of the things that we can do to help in this situation? Pain management, absolutely. Yeah, pain management for his daughter, 100%. That can help a huge amount for him. So much of his worry is around seeing her suffer. Psychosocial support, absolutely. Yeah, for his daughter and for him. 6-year-olds know a lot about what's going on, right? Counseling, yeah, Spike. Yeah, so in terms of like sharing the news, thinking about how to really gently and carefully share the news. I love the highlight of family counseling, right? Not just thinking about one person in isolation with this family unit, how to support with family. Yeah, support and love, just being present, validation of their thoughts and feelings. That is huge. It's huge. This is normal to feel this way. This is hard. This is scary. This is an awful situation. Not running from that, not hiding from that, not fixing it, right? We can't fix the fact that it's awful and hard, right? I think that's something we really feel as healthcare providers really want to fix that. We can't fix that. We can't fix that this is full of grief and tragedy and heaviness, but we can sit with people in that. Some of the things I know we've talked about already, recognizing this is trauma, right? Sitting and listening to his story, hearing about all those pieces they've gone through before, that helps inform us, let us know sort of what's playing into all of their experiences and feelings. And then all the things you said around showing love, being present, saying, this is so hard to see your daughter in pain. This is so scary for you. And then again, thinking about changing the environment, could the child be cared for at home, right? Giving accurate information about the prognosis and what's going on with her, and that she already has metastases into her brain, can help them make decisions that might be important for them financially, or might be important for them in terms of where she's cared for. And being honest about that, even though it's very, very hard to be honest. So again, sort of thinking about this 3-step approach of developing a trusting relationship by actively listening and being present, which is hard because it means sitting with hard, painful things, expressing empathy, and then thinking about if we can change the environment, what that would look like. And then again, highlighting what are the other things that we can help with the coping, right? So maybe they haven't had really clear explanations, and that fear of the unknown that you guys brought up before is actually really hard. So sometimes, even though it is really hard news, to share that hard, accurate, proper communication about the disease and situation and prognosis. And then some of those coping skills, right? If we need in the moment to teach breathing exercises, relaxation techniques. Another thing that in the moment, if someone is getting really, really anxious, and especially if they're in like a really acute traumatization experience, we often do something called grounding. And it's very simple, where we just have people, I have people just sort of put their hands on their chair or on their lap and just focus on touching what they're touching. So just focus on sort of, what your hands are feeling. You can do things like rub your hands together and feel your hands, just move your fingers and feel those. You can have them touch their clothes and just feel what their clothes look like. You can have them look around the room and just point out colors and say what colors they're seeing, like green, white, just to kind of come back into their physical space here and focus a little bit on where they are and feel their bodies again. And I think Anne already mentioned this, and Erin echoed this as well, but I just wanted to re-highlight the importance of recognizing that this trauma impacts us, and recognizing that it impacts your teams and our teams. And if there's one thing that you do, it should just be talking. It's very simple, any sort of debrief. And it doesn't have to be fancy. It doesn't have to be anything in particular. It doesn't have to be too super organized. It's just providing a space, a psychologically safe space where we all can sit and have effective, open, and respectful communication and just share. There's some cases that impact us more than others, and there's some things that just re-trigger things in us. We all have our own histories, and many of us have trauma in our histories. And I think just giving a space for people to express how cases impacted them is really important. There are lots of interventions we can do, and we actually have providers who are being really impacted by these things. I talked a little bit about grounding. You can sort of scan your body and just look for tension. Like I said, you can touch things with pointed colors. I had a provider once, a chaplain, who advised us to say a moment of self-compassion. She would put her hand on her chest and she would take a deep breath and she would say, I am doing my very best in this situation. And that is good enough. All human beings suffer. We are in this together. Even just taking a pause with a deep breath. You know, even if you can't remember exactly how to do a breathing exercise, you can sit and take a deep breath. I do this with my children, or at least my 3-year-old, all the time when he's in the middle of something really emotional, or some trauma for him that feels really, really huge, even if it's a small piece that's upsetting him. Just taking a breath, and attention management, shifting your focus to something else that's not as charged. So I'll pause there, open for questions, but also hand back over for our group discussion portion. Thanks so much for having me. Very happy to be with you today.
Thank you. I am called Hassan Adan Ali from.
Hi, Hassan. Welcome. We lost you for a minute.
Yeah, I am called Hassan. I am called Hassan Adan Ali. I'm calling you from Somalia, especially Baydhabo. As we are aware that the Somalia, there's a lot of trauma, and the people need a lot of counseling and talking about the things. And we really appreciate the way you are teaching us. So the other hand, you may see that someone has stress or cancer has a trauma, and that person is maybe is emotionally, you cannot talk to him and counsel him and talk to him in a manner way. So then maybe you may meet with that person with a reaction, or he may beat you or may done to you something. So I personally, I will be urged to focus on how to counsel those people for their daily and activity. And I really appreciate, although we are in Somalia, there's a lot of stress. There's explosion every time around. By the time the person, you may see that 3 person, brothers and sisters, are moving together in one place, and maybe they meet in incident or explosion in a certain place. Maybe you see that the whole family remaining one person. You know, when you see such cases like that and people taking stress and trauma, it is very difficult even to be contact with that person and discuss with him. So I personally, I could say, continue every time how to connect with those people, like meet those people incidents. So thank you very much, and I don't have any question. The other question I have is, by the time we finish the course, are we getting certificate?
Yeah.
Thank you very much.
Yeah, I can answer the easy question first. Yes, you can get a certificate. You just are required to make sure that you attend every session. So you can either attend the session live or you can listen to the recording afterwards. But I'm hoping that everyone who's registered for the course can get a completion certificate. So that's the easy question. The harder question, Dr. Jessi, you and I can kind of try to manage this, but I think part of the concern that you had shared and brought up, and I'm not sure we talked about it too much, but what to do when patients become quite aggressive because of the trauma. So they're in the facility because of their illness, their current illness, but then how do we manage when people are aggressive or agitated?
Yeah, there's a lot of
Yeah,
sorry.
thank you, Hassan, for that question. I think that's a really good question. And your question is, you know, even bigger than that, right? How do you care for people who don't seem to want your intervention or your help? And I think that's not uncommon when people have a lot of bad experiences, maybe distrust in the system, but also just a lot of the emotions that you were seeing come out with many of those cases that you guys beautifully named, including anger, are really normal in trauma. Those are really normal. And it's very common and expected, right? It makes sense to be angry. It makes sense to be scared. It makes sense to be distraught and to have that come out in different ways for different people. And I think one thing with trauma is that we cannot fix everything, right? We can do the best that we can do with what we have on any given day. And that is really hard to give ourselves the grace to do the best we can. Sometimes that may mean that we are present and we say, we're here for you, when and if you need our help. And that may not be the day, right? That might not be the day that you counsel people. I also think actually naming things like anger can be really helpful. So sitting with someone, say, you're really angry. You know, it makes sense to be really angry in the situation. You know, this is really scary. This is really hard. This is not fair. You know, there's been so many things that have happened, and there's no world in which you wanted to end up here, you know, and go through all these things. And just honestly sharing that, right? And honestly naming that. A lot of people you will find in hearing someone honor and name their anger will actually become more calm, right? Because they feel heard and they feel seen, right? And that is what we all want. We all want to be seen, right? We all want to be our authentic selves and to be seen. And I think that's really, that can be really huge and helpful. And it may not be, right? That may not be the day that that person wants to sit for counseling. And that's okay too.
There's another question here. How do healthcare providers do we re-traumatize our patients possibly unknowingly?
Yeah, I would love to hear from the group and hear thoughts. Type in, speak up, or there, because I think that's absolutely the case. That's true of everyone. What are ways, and I see Agnes too, ways in which healthcare providers traumatize patients? Yeah, labeling and branding patients, invasive procedures, coercive practice. Please, anyone else, feel free to type things in or type cases, type in brief summaries of cases that you feel like you've seen that. I think that's an important thing for us to, in the United States, we are doing a lot of reckoning right now around our own bias, around our racism, which we know is very pervasive. And I think a piece of this is how do we, so I think how was some of the ways in the United States we traumatize patients is in subjecting them to systemic racism, to all sorts of bias. And I think labeling and branding patients is absolutely a way in which we subject individuals to trauma worldwide, but in making assumptions, right? Making assumptions about people, either intentionally or completely unintentionally, without even thinking about it, which is a huge portion of bias. So I think that's a really important thing to bring up and for us to think about and be aware and not hide away from and be honest about. I see doing the wrong procedure to patients. Of course, that would be incredibly upsetting, right? Giving the wrong medications, wrong procedures. I think that one's a dramatic version of it, but medical errors, right? Errors in general. We make small errors all the time, right? We use the wrong name, or we, point to the wrong arm and get that small things, right? And we give the wrong medication in small ways. And then big things, right? Big things like doing the wrong surgery, but the whole world of errors, where errors happen, we're human, but acknowledging those and being honest about those and apologizing, judging people I see. Anyone else want to share something? Type in or come off mute. Breaking
Dr.
confidentiality.
I saw you unmuted. Do you want to?
Hello,
Hey, how are you?
I'm good. Actually, I was about to say that healthcare providers can re-traumatize the patient even without knowing that they are doing so. For example, if they don't understand what the patient says, the first thing the patient will feel guilty or wrong about what he thinks or what he's expressing, and that may harm her, may be more harmful to the patient more than it was. And I think it can increase the trauma of him or herself.
Yeah.
Absolutely. I would say most providers probably do not know they're re-traumatizing patients, right? I think if you asked any provider if they wanted to cause harm to patients, we would all say no. And that's why it's so hard for us to be honest that sometimes it happens, and to be kind to ourselves that it's not on purpose, but we can think about it, we can ask about it, we can work together to do better.
Yeah, that's why I think that we have to be more careful about what we say, about what we do, and try to get some empathy. That's what will make us like different to others who may come in the career. Because I think like healthcare providers should feel like what we are doing is just vocation, not just doing what we learned in schools or we learned from different trainings. Just do it like a vocation, if I can say so.
Calling, I guess. There's some good points coming through. Patients need to feel validated. I've seen a lot of invalidation occurring when dealing with someone's trauma. I think that's really important. Using choice words while working with trauma patients also matters. Thinking, I guess, before we speak, kind of a phrase I'm sure that our parents may have said to us when we were little, but yeah. A longer comment here. Sometimes a patient is diagnosed with early stage cancer. They're treated with a curative intent. Then when there's a reoccurrence, it's difficult for counseling by the same team which started the treatment. What is your advice when a patient is no longer trusting the team? In this case, a recurrence. I think this is really good, especially for integrating a palliative care approach, because we know many of you, again, are not necessarily working only in a palliative care setting, but Dr. Jessi, do you have any comments on that? How we help with building that trust?
Yeah, I'm happy to. I wanted to comment quickly to the one right above from Kimberly around patients needing to feel validated, and just really highlight that it's very common, and Kimberly's mentioning seeing a lot of invalidation. It is very common when people tell us hard things, this is very human, that we say, it's not that bad, right? It's not that bad. At least you have one child left, right? You didn't lose both of your children. At least you have one child left. At least, your pain is better right now. Well, thanks God that at least at this point in time, your mother is here. Try not to do that. Try not to do that. Because that's a way to make us feel better, right? We're doing that because we are suffering and hearing this story, right? That generally does not make people feel better, right? They are experiencing their trauma. That may be true. There may be good things, right? But honoring their experience and trying not to fix and trying not to compare, right? Your trauma is not as bad as this other trauma. Suffering is suffering, and trying as best as we can not to do that, I think, is really important and a core component of trauma-informed care. So thank you for highlighting that. This other question, very hard as well. How do you respond when the patient is no longer trusting his treatment team in case there's occurrence? I think the question of trust is really huge, right? And this happens all the time, that a patient may not trust whatever the team may be when you come in, or they may not trust your team. Some other team may come in. I'm happy to comment, but I'd love to hear as well, how do you guys deal with trust? How do you guys deal with when you come in and a patient or a family may not have trust in the system or have trust in their prior team? What are some of the things that you do in working with that team to kind of try to build that trust again?
Is anyone interested in sharing? I know from my experience working in East Africa, it is very difficult. And I think several cultures identify truth telling differently. So then therefore it can be really difficult if your patient values certain things that you maybe don't value, to gain that trust if that trust has been broken. Sandra, would you like to share? Maybe not.
And seeing some comments around like, looking for alternative healthcare workers. Certainly if they've seen one team and don't have as much trust, as you said, you may be coming in as a separate team. Being humble, I think, is really important. Being honest, whether that's that things have changed, I think, or that maybe there was some misinformation. In this case, I don't see that there's misinformation. It just sounds like there was curative intent initially, and now we're in a bad situation of a recurrence, right? And we have a different prognosis, and really being honest about that, right? So the way I share those sorts of things is, I have bad news. We're in a different place now. We had hoped to cure the cancer, but it's back, and I worry we won't be able to cure it now. Right, so sharing news that's simple and focused, and clear with people, and being honest that things are different, explaining why things might have been shared differently in the past, right? Because I think that confusion is some of the trust that's not built there, and sticking with it. Like, a lot of trust is built just by showing up, and being there and staying there and being there with them and saying, I'm going to walk with you every step of the way, right? Even if it turns out we don't have a cure for you. A lot of people feel abandoned when they're not getting treatment, right? But how can we still care for you? How can we provide care even if we're not giving chemotherapy or what it may be? I see consider the family suggestions and trying to find answers to their problems. Yeah, really asking them, what are you worried about at this point in time? It may be different from what they were worried about before. Reinforming them, psychoeducation. Yeah. Allowing people to make an informed decision.
I think sometimes it can be hard, especially with recurrences. Many people, including the patient, may be asking why. And I think just this idea that the medical team should be able to answer that question kind of makes them seem almost like superheroes, which we are not. So in that sense, it can be really hard. They put so much value and trust in people. And then when we aren't able to answer some of those very difficult questions, sometimes we don't really know what to say, so we say the wrong thing, or then we worsen this trust. But I think this idea that we need to be honest and humble, I really like that. I mean, there's many reasons, especially in refugee settings, as to why recurrences can happen. It may not be a simple answer as just the physiological recurrence of the cancer. So I think that probably also plays a big part in it. We may not necessarily want to openly talk about all the barriers to access to treatment when we're sitting right in front of the patient that's had a recurrence. So I think some of the discussions from today have pointed out a bit of a bigger picture, but of course, we also want to support you in those moments. You obviously are not going to be able to solve all the system issues, but I think the system issues are very, very serious still. So taking the weight of a recurrence on you personally is not going to necessarily help. I know there's a few more comments.
Just recurs. It just comes back. And I agree, Erin, like even though sometimes you're thinking, well, this may have recurred because you didn't finish this treatment or you were gone for a long time, or I try not to bring that up because I don't find that that's helpful. I don't find that helps people feel better. And maybe that's for me, maybe that helps me feel better, but I don't find that helps other people. And I think it's important to remember that some people did their treatment and left and never came back and didn't have a recurrence. Right? Like, I think that's important to know. It's not just that they didn't come back or they were lost to follow-up or whatever. There was some randomness too, right? The universe happened And people ask this to me all the time, you know, they're smoking and they get lung cancer. Like, did I cause this? Like, some people smoke and they never get lung cancer. Right. So it's not just your fault, right? There's also some randomness in the universe that we can't predict or control. And so I really try as much as possible to not place blame or focus on who's to blame for these pieces.
Yeah.
There's a message or a comment here from Annalise. We'll probably try to wrap up in the next few minutes. So if you have any burning questions, put them in the chat or raise your hand and we'll have you unmute. Annalise is one of our faculty members. She's been a palliative care nurse with IRC for many years in Kenya. She's working in the same camp where Ali is working. She says, is it bad to apologize to a patient? Like saying, I'm really sorry if I hurt you last time. I promise to be careful not to repeat it again. So this posture of apologizing, what are your thoughts on that?
Yeah, and I mean, I'd love to hear from you guys too. I think apologies are very, you know, there's some cultural issues around it, and it's different in different places, and sometimes we think of legal issues. I will say that my personal belief, and what I think we've seen in studies too, is that apologies are almost always the right way to go. You know, if we've actually done harm, apologizing. And I know, you know, this is not the metric I care about, but in the United States, they've done some studies and they've looked at apologizing versus not apologizing for big medical errors, like wrong surgery or big things, wrong medication that hurt somebody, and whether or not patients and families sue, right? Like, you know, legally attack the doctors or providers or hospital. And if you apologize, it decreases the risk that someone comes at the hospital or the doctor. Now, that's not the reason to do it, I don't think, but I think that that's a sign that oftentimes people are just looking to be acknowledged, right? And looking to have that sort of honest human apology. And I think a lot of times trust is built hugely in people saying, I made a mistake, but I'm still here and I'm gonna try to work better and work with you better. And when I take a patient into our hospice, into our hospital, I'll often say, we're going to try to work on your pain. We're going to try to work on that. We may not get it right. We may get it wrong, but we're going to be with you to keep trying to get it right. We may even make mistakes and do the wrong thing. You may have side effects you don't like, but we're going to still be here. And we want to hear your honest information so that we can fix and do better. And I think that goes a long way to building trust.
Yeah, I think just in the word that you used, Annalise, promise, I think I wouldn't be hesitant to use that, but just aware of how you use that. I think we need to be careful what we promise, because there are many things, again, that are out of our control. I think if there was something that really impacted you personally, of course, you want to be very serious with your patients. Because you obviously are also impacted by the thing that happened. Using the word I promise gives so much weight, and it's really helpful in many situations, but just be aware of how you use that with your patients or the families, because there are sometimes things that are out of control, and whether or not you promise to do one thing or the other, I think people kind of cling on to certain words. So just be aware of how you use that. I'm not sure in Swahili or Somali how the word promise means, but in English, I would just say just be aware of how you say that to them. I'm very sorry, everyone. I forgot to share the attendance list much sooner because we've had such a intense conversation today, but the attendance list is there. If you need to head out, that's okay. We'll just take one more comment. It's from Lamek, our resident nutritionist, which is great. So what I think, Lamek, this is what the whole session was about today. But Dr. Jessi, if you can wrap it up in one sentence, in a situation when you find a patient is traumatized and very moody, how can you approach those situations?
Yeah, no, I love it. It's a great wrap-up question. I think the first thing, and really if you take one thing away from this, is even just recognizing it as trauma, right? Like recognizing it as trauma, being present with patients, showing empathy, asking questions about how you can support. that is in and of itself huge, right? Showing up. And then I think what we did, that practice of sort of trying to guess at people's emotions, is actually huge. So, right, so moody is a great word because it's sort of non-specific. I don't know, is he angry? Is he have guilt? Is he in despair? Is he scared? Trying to ask yourself what he may be going through, and then try to name those emotions, right? This must be really scary. This must be really upsetting. You may get it wrong, and then hopefully he'll correct you, right? He'll say, no, I'm not angry. I feel, awful because, my child was injured in this motorcycle accident, right? They'll correct you. So sort of trying to honor and name those emotions, and then continue to show up, to continue to be there, and try to think about how you can ask more questions and work with them, meet them where they're at. That's a great question.
Yeah, I think also I'll just end as we are wrapping up for today. I think it's definitely a team approach. I'm not sure we talked about that too much, but if you come into a situation and you feel like the patient is just not responding well to your interaction, whether you're a bedside nurse or the primary physician, whether you're the social worker or, if you're a nutritionist, Lamech, for example, I think even going with another colleague to the bedside would be appropriate, knowing that you don't necessarily have to face those kind of more volatile situations or situations where a patient is not really interested in interacting, trying not to do that by yourself. So of course, don't bring a team of 20 people around, but I think it's important to know that you don't necessarily have to go to these kinds of situations by yourself. All right, thank you so much, everyone. We are more than halfway through the course. We have a few more sessions and then we're going to take a break for Easter. Next week, we are on week 8 and we are talking about breaking bad news. So how do you support patients that have recently or have had an experience where they have a new diagnosis or their prognosis has been shared, and how do you share that with patients and families in a way that's appropriate? And there are kind of some methods that you can learn from. So that's what we'll be doing next week. Thank you so much for being here. It's great to have you. Thank you, Dr. Jessi, for
Thanks for
your
having
great
me.
session.
Thank you very much.
you.
It was enjoyable, and we have gotten a very important topic today we have discussed, and I really appreciate the way you are every time to support the people who have the trauma. I really appreciate. Thank you very much, and nice to meet you next time.
Thank you, Hassan.